speaker, feel free to come up to the microphone and I'll make sure, audience questions come first. So I'll ask the first question, or actually if you're here, go ahead. Yeah, that's awesome. Thank you, Kate.
Yeah, of course.
And feel free to introduce yourself just because not everyone in the room knows each other.
Hi, my name is Kate Spector-Baghdadi, and I am law and bioethics faculty at the medical school. My question for you is, so you both talked about trust in the context of clinicians trusting the AI. And my question for you is whether it matters whether patients independently trust the AI. And I'm not trying to set you up at all. I think it's a really important question. But if patients trust the clinicians and the clinicians trust the AI, does it matter? Do we care if the patients would independently trust the AI?
I think you're going to get 2 more talks today that may come closer to that answer, and I don't want to say that I'm the authority on that, but
I know, but it's important
it's very
to
important.
ask the people who are developing the models as well.
I mean, I think it depends on the use case, right? So there's a lot of things that we don't know what doctors are using to make their choices, right? And so we do just fundamentally trust them. There's no reason that AI can't just be another tool, right? It's another lab test that they're thinking about, right? So in that sense, patients might not even be thinking about whether or not they trust the AI. But if you're talking about a case where you want to be able to have shared decision-making and say, this is what my tool says is your probability of success with this really difficult treatment plan that we have for you. And we want you to think about how that matches your values and your preferences, then we do need to make sure that they're trusting it too. So, but it depends, right? Sometimes it's completely transparent to them, and they don't know that we're using it, and maybe that's okay.
Yeah, you don't really ask your surgeon which scalpel. You don't, hey, your surgeon doesn't come in and say, I have 5 scalpels I can use for the surgery today. What do you think I should use, right? So if you consider this a true tool for care, I think there's some deference, and we talked about kind of shared decision-making. I'm a pulmonologist. Whenever I get into the weeds about lung cancer screening with my patients, they actually get flustered with me, even though CMS mandates that I do exactly that. Here's the risks, here are the benefits. I'm like, that's a mess. But I want to screen. What am I supposed to do? So, I think it's more important to just not, they still have the agency to make these decisions. If they want to say, I'd like to opt out of any AI stuff you're doing, I think that's different from, I trust you, and if you think this tool is going to be helping you care for me, then, we can't bury our heads in the sand either, though. And so I think transparency and communication are crucial. And we've talked about that treatment for consent. When you come into a hospital, nobody reads that, but that probably needs to look different for learning health systems.
Cool, thanks.
One of the things that you brought up, I feel like, is the idea of shared decision-making. So not every decision is preference-sensitive. And so that's why certain preference-sensitive decisions, we go to people and we actually do present the menu. We say, we can do surgery or we can do radiation, and here's the pros and cons of each one. Here's what I recommend, but there is a kind of a more robust conversation. To the lab test example, I think it's interesting because on the inpatient setting, we draw all kinds of labs, and people don't get a lab-by-lab summary of it's okay and here's what I think about it. On the outpatient side, that's almost the norm. Anytime you get labs done, you're expecting to get some kind of letter. It might be very short, but it just says, all looks good, but you're expecting an interpretation. So even the expectation on labs, I feel like, is different inpatient, outpatient. So, I don't think we've ever sent, for a sepsis model, your score 15 minutes ago came back at 5. That means blah, 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 blah. One, there's not a preference-sensitive decision there. 2, it's more of that inpatient cadence. But that is interesting. When should we be informing patients, when we do get a score in the way that we would for a lab test as an outpatient?
We are to that towards patient transparency and involvement in care. I think several organizations are actually releasing labs for inpatient settings, which creates a very interesting rounding experience as things trickle in.
Thanks. Great presentations this morning. I was learning a lot already. Questions about some of the lessons
You
learned.
want to introduce yourself?
Oh, I'm sorry.
Yeah.
Michael Shepard, Michigan Medicine Data Foundation's director and co-chair of the Clinical Intelligence Committee. We actually are kind of Michigan Medicine thinking about these issues of governance as well. Some of the great lessons learned you shared there, how much of that is codified? How much of that is owned and published? And where is that workflow understood in your organizations, and how are you building that up and socializing it so it's kind of more of part of the ingrained life cycle of development and models?
That must be for me. So it's a process, right? So we're standing up, a committee for AI. We've talked about how many people need to be on there, how many people don't need to be on there. Are we making recommendations? Are we actually the authority to make decisions? And the problem is, especially when it comes to the Gen AI space, everything's got and also we have AI. And so it's a fire hose for a single group to drink from. The secret, and this may not be I think it's fairly obvious, right? As a clinical informaticist, I have the keys to the electronic health record, so I have a little bit more of a vote when it touches patient care. But there are things that are going on in the periphery that are not integrated, and because they're not integrated, they probably won't work if they touch care, that we try to rein in. But you know how it goes. When an executive signs, I want this, I like it, we already have this, it's working great, and then that's the governance piece. We just have to keep having these conversations. So I don't have the answer other than, like I said during my talk, if you want to be a good informatics leader, that means a lot of meetings and a lot of kind of governance to go through.
I would agree. We're actually having really complicated conversations about what aspects of monitoring for our models is research versus operations, and who owns that, and we don't know yet.
Hi, Nicholson Price from the law school.
A lot of mic drops this morning.
Nicholson Price from the law school. I love the juxtaposition between here is a challenge for resource-constrained institutions to do governance, and it's a really hard task, and figuring out if this works is really complicated. And doing this stuff well requires lots of work on people, not so much on tech. And then the third point, a recommended solution to figuring out this task of governance is tech. And so I'm curious as to how you reconcile those things, like the idea that tooling is gonna help make this easier. Does that run into the same sorts of, no, this is actually a people problem, or is that different because the people problem here is just governance people, and so we can have few of them, and it's not doctors who are different, require buy-in from a different sort? What's that?
You can say it. We're hard to work with. I mean,
I would never say such a thing out loud. I guess that's my thought. How do we think about reconciling those? Do we need other stuff besides better tooling? What else do we need? Is technology going to solve this part of the technology picture? What do we need?
The tooling and the technology make it more accessible, and I'm going to say explainable, but I don't mean AI explainable. But I think it gives you an opportunity to just rein everything in a structured way. But the people problem is the people problem. It's people and process. And if you think about what healthcare systems should be spending their time and energy and money on, it's not niche new AI things. It's doing the things we actually know work today, i.e. implementation science and quality improvement. That should be the focus. If you want to talk about where to spend I'm not just saying this because Brooke's in the room, but if you want to spend your dollars, make the care the way it's supposed to be, and you do not need AI for that. So I think it's still not baked itself in. I mean, there's probably applications where AI can help you clean up the data, where better tools can make things more immediately obvious or readily available. So it may turbocharge, like a lot of these Gen AI things, right? It can turbocharge your process, your work process, so you can do more. But the hard work is still the hard work, which is getting people into a room nowadays, never in person, virtually, but just to understand the issue that you're trying to solve, your proposed solution, and how you're going to monitor and measure and keep that cycle going. So I don't know that any of these things make it that much easier. You're still going to have to deal with that governance and people and process.
And so that just means lower resource environments are still going to be out in the cold?
Very much disadvantaged, right. So the tooling, the case that I was making, was the tooling could make it so that you don't need, I can do R, right? There are healthcare systems where there aren't people that can do that kind of work. They should not be playing in the space because the tools that the current vendor provides are just generally inadequate, right? So there's just much more guessing, and you get caught in a very kind of embarrassing situation when, Current Deep Study drops and everyone's like, oh, we use that, right? So You know, and a part of this too is that learning health systems, if you're going to be a learning health system, then apply the correct structure and process so you know what you're doing and you're monitoring and measuring. There's a lot of rampant A/B testing that nobody has control over. And so even individual departments decide one day to turn something on and figure out if it's going to work or not. And that might not even be on our radar.
Andrew?
Andrew Rosenberg, I'm the CIO for Michigan Medicine, and I appreciate this conversation. Kate brought up a question that was interesting to me that I'd like to come back to in a different way. I was lecturing undergrads the other week on AI in healthcare, and several of the students asked a very similar question to what Kate did about how do we make decisions and how do these tools and processes support that, or what will be different. And I'm going to get to a question for both of you, but give me a minute to get there. What I see happening among students, our faculty, our staff, our leaders, I believe we're still trying to figure out how to ask the right questions. And it's similar to Einstein's, apocryphal point: if given 24 hours to solve a problem, he would take 23 hours to figure out what's the question. And I say that because I'd like you to maybe comment on this. When I thought about, Yasser, your presentation, I thought you showed something very interesting in both the ED, as opposed to all of healthcare, a very specific area to look at sepsis, also somewhat of a syndrome, but in critically ill patients in ED. So we're already starting to narrow, where does this tool work? Or in optimizing no-shows. I believe that one of the things that we can still work on is how do we continue to help focus critical questions for where people make decisions and how, because we're all over the place. It depends on who and when and what context. But we can focus what exactly we're trying to do to see where these processes and technologies solve a given problem. And my experience so far is that we're still starting with vague assertions of how will AI help us? That is so obviously not a question that's answerable. That's not remotely close. Right. So the question then might be, in your experience, how can we continue to improve the focus of the questions that solve a particular business need, and where we know the technology and where our decision-making and our processes and ethics around decision-making can align to a more focused method to work on these problems? Wasn't the best question, but I'm trying to get to that issue of how do we continue to ask questions that are more focused.
Take a stab at it?
No, I'm still thinking about that.
Well, let me add to it. So, and this may stimulate some interesting debate. The optimizing no-shows you showed actually worked, depending on your point of view.
Right.
Right. It actually worked to decrease no-shows, and it potentially did not solve another problem around access to underrepresented patients, or it potentially created a new problem, but it did answer at least one person's question. And I think one of the challenges that I see is that because these questions are not focused and precise, what appears to be a good answer becomes a problem for someone else. Mm-hmm. And then we're still not moving forward. But if we said, I just want to optimize no-show, that's all I care about, you would have said, we succeeded compared to where we were before. And I think that it's and by the way, I'm not advocating for what I'm trying to advocate for is how do we clarify our questions so that we can then say, but now we have to deal with it in a broader context of equity, of access. And maybe there's a way to turn the dial even more, mm-hmm. but we first demonstrated we can do it versus we can't even do it. We cannot even figure out an automation to maximize it. So somewhere in there were a few questions.
So one of the things that I would comment based on those points was, so I think how we define impact is really where it comes in, and making sure that we have that at the beginning and not afterwards when we find problems. And in terms of how we long-term think about implementations, I think that specifically comes up because similar to the no-show problem, we have examples of models that, for one population, it's fine. It's not changing, and it's doing exactly what we expect it to do. But for another population, it's getting worse. And when we've applied updates that correct that, it only corrects it for one of those groups and not necessarily the group that needed correction. And so how do we move forward from there? And I think that brings together this issue of measures of impact, measures of statistical properties of things are never going to give us the equitable answer. They give us information that you can only use to interpret with a larger ethical framework about how we think about what we want the impact to be. And so the data is not going to tell us if something is going to be impactful in a positive way on its own. It's all about interpretation.
I agree. I'm all about that. So it's, rubber has to hit the road. We need to know how this is going to work in the real world. And for organizations that have missions that are equity focused, then we tune our models accordingly. For organizations that, for better or for worse, obviously mostly for worse, like they care about just generating access regardless, then they're going to optimize for access, and it's going to disadvantage people. And so this kind of begs a little bit of the question of kind of dog wagging tail, tail wagging dog. It's a tool, right? So I live in the informatics world. I liaison with our executive leadership, and they say, this year, our goals are A, B, C, D. And then my answer is not, let me go find you some really cool AI models to solve these problems, because more often than not, the solutions actually got nothing to do with anything remotely intelligent, right? And so we shouldn't be, I think there's just too much, we're still in that hype cycle. I keep waiting for it to come down. I think for Gen AI, it's maybe starting, coming down, consolidating, plateauing. Something's happening where people are starting to realize that ChatGPT is not as smart as it looks, right? Again, if you are looking for solutions that only meet the AI need, then you're walking around with like the key looking for a lock, and it's the hammer nail problem. But we're trying to solve more fundamental problems in a healthcare setting. So that leaky pipeline that Sharon showed, a lot of those dropouts are, we didn't even need this, right? This was a great academic discourse, really nice paper. You did some cool stuff that I think is definitely really useful for the space. But downstream, I'm not even looking to predict the risk of this thing that you're predicting, because I actually don't have a solution for it. And oh, by the way, my burning problem is transportation. So I'm not totally sure how your AI is going to solve my transportation unless you can make like an Uber AI, which I'm sure already exists. So again, I think you're right. It's what is the problem we're trying to solve, which is the key question healthcare leaders are dealing with today. And then you have the whispers from vendors saying, our solution has AI and therefore it's better, but that's not true. And we were talking about this at dinner the other day. You can tell the more mature vendors from the more recent ones, because the recent ones are like, our C statistic is awesome. We can predict this. It's going to be great. And then what's my ROI? What's my implementation cost? How many people do I have to get on board? How much change are we talking about? And what is the actual impact of that change? So the more mature vendors are saying, yeah, the model's fine, but here's how we're going to partner with you to implement this, and this is how we think it's going to work, and this is how we think it's going to benefit your population and your process. And that's because they've had they've got the burn marks, right? They've been through it. They've been through a couple of steps where they're like, oh, it turns out nobody actually really cared about this. So I think it's I agree with that 100%. What are we trying to solve for? And it does not start with AI.
Two questions. I'll ask one question. Go ahead.
Yeah, just a very quick question. Nabil Rad, I'm with Michigan Medicine Health Information Technology Services in Analytics. Great presentations this morning. The question I have, and maybe this relates more to you, Sharon, and maybe a little bit to you, Izzy. When you monitor, you're monitoring a model for existing data and trying to optimize the implementation over time. What happens when new data sources come into play? Are we looking perhaps into champion challenger models that we should be considering in the monitoring equation? So I wonder, what is your thinking about not just Because what happens over time is you could be very good at climbing a mountain, but now it's the wrong mountain to climb. And I wonder how you're embedding in your monitoring thinking and philosophy the idea of a champion challenger when there are new data sources being included, and there's really data innovation in the space that should be considered as we move forward.
Nabil, do you have an example in mind? Like that's a broad question. I'm trying to think. Like when you say new data source, do you mean like imaging data? Or like,
Yeah,
like,
there's,
what are you
all of a
thinking?
sudden there's more unstructured data. There's imaging data, video data, right? Maybe speech data that wasn't being taken into consideration before, and now these are sources that sometimes people overlook because they're maybe either hard to understand and they don't even try.
So that's why I think that it's not just data-driven management and maintenance. I think that we need that comprehensive view where we have those teams that have that view of the landscape of, here's a new way we could think about predicting this. Maybe we need to fully revise the model, and that's something that takes actual people being involved in making those choices. And so having the larger structure around not just the data part that's running in the background, I think is really important to make those choices and drive those larger changes, because we do need those, right? Like when we understand a disease better or an outcome better, or we know a process has changed, we have to fundamentally change the model, and the model's not going to necessarily tell us that.
Hello, Mohammed Atiya. I'm a clinical informaticist with Pfizer Medical Affairs and a clinical adjunct faculty with the University of Michigan College of Pharmacy and past employee of Michigan Medicine a few years ago. So a question for, maybe more for Sharon. You talked a lot about monitoring the discrimination,
Calibration.
the calibration, yeah, calibration of the model. Are there like instances where you also need to monitor for discrimination? In instances, maybe calibration will continue to look good, but PPV drops significantly? Or?
Yeah, so there are typically discrimination has traditionally been thought of as pretty robust, although there are more recent examples, especially with very large abrupt changes like during the pandemic, of discrimination and more risk categorization focused metrics that have started to fall off. There was a study at, I think it was UPenn, where they had a model that's true positive rate dropped from 81% to 74% during the pandemic, which really changed who they were addressing based on the model's prediction. So it isn't just calibration that can have those problems. If I always tend to think, and I'm certainly biased, that if we can maintain calibration, then where people fall on the right, people keep falling on the right side of all of those thresholds. And that's important. But there are also examples where you're really just interested in rank ordering your patients, right? And you only have capacity to reach 10 people. And so it's only the 10 highest risk people that we're concerned about. And so in those contexts, calibration might not matter as much, because where they fall doesn't matter. We just need to know who the 10 worst people are. So it's really use case driven.
Thank you.
Hi, I'm Bob Bishop. I'm a private citizen. I just sold a company last year to a major orthopedic company, which had over the last 25, 30 years collected x-rays from orthopedic offices throughout the United States. And it sold for a ton of money because they wanted the data. And it's an ongoing data source. So an article from last month caught my attention. It was by some radiologists in the Netherlands that were asking the question of what is intelligence, which I think is missing in these conversations. And I'm not saying I know, but it cuts in the question of what is generated. And so one of the questions is, does it create or generate a prediction, or does it generate an explanation? They're quite different. And I think you, as a clinician, are looking for an explanation.
I would debate that,
But
yeah.
I don't know. But I think we're all missing that is a paradox, because as they point out, in the way that we are currently creating machine learning, it is a prediction model. Is it an explanation model? And they are clear in what an explanation is. It's how you can explain phenomena of reality, which I like. Predictions continue to move you toward Shannon's uncertainties, which you're constantly you're never getting there. You're constantly uncertain at some level. And so what I'm trying to get to here is, where's the ethical boundary that we're trying to deal with here in intelligence? And when we bring it into these new models that are no longer human models making decisions as to how patients are going to be treated, where do you come down on the ethics of what we're looking for out of these models? What do they need to generate? Perfect predictions or better and better explanations?
I'm going to land on neither, and I'm going to say actionable insights. So I'm going to tie in the question about, are we asking the right question for sepsis? So when I have a patient who's critically ill or I suspect could have an infection leading to sepsis, what I really want to know, we don't sit there and think about, do they have sepsis? Do they not, right? What can I do for this individual to give them the best outcome? So if I can validate that responding to a model to get an antibiotic in faster actually can improve someone's outcome, and the next step is just the antibiotic, then as a clinician, I'm good. Because the secret is, we don't know how half of the things we use work. We use medications all the time. We were talking about this last night. Here's an antidepressant. It does something to serotonin. Oh, wait, actually, it has nothing to do with serotonin, but my patients are better off for it. So as a clinician, if it's not explained, then I think you're talking about the ethics of it, I need to give them the thing that I know works. And so I'm kind of, frankly, over sepsis early warning systems. I'll combine some points here. Everyone's recycling the same 20 variables in the electronic health record to build a model, and they're all fairly decent. Like, let's just move on from that. But none of these models are telling me for this particular patient, like embracing the concept of heterogeneity in treatment and the effect of treatment and heterogeneity, like that isn't answered by any of these models. So the next step from my perspective is to create the actionable insight. Now, if you can conveniently connect it to physiology and pathology, that's phenomenal. But that slide that I had up where I said, being seen by a priest means you're going to die. Like that, this is what happens when you start talking about explainability, because the junk that we're shoving into these models, they're all surrogate measures of things, and they're not the actual thing. And if it predicts better based on the things that we have, and I have to lose accuracy or potential for treatment based on just being explainable, then I would say it's probably incumbent on us as clinicians to rethink our kind of treatment and assessment paradigm to say we need to understand what this means and understand the power of this in care. And so like bringing in new data sources, I'm all for that in sepsis. I've said we need computer vision, because as a clinician, there's just something that I know when I walk into a patient's room and they look like, like I can see that and I know that they're gonna be sick. And I don't capture that in, vital signs every 15 minutes and nursing assessments that go into the chart, right? So we do need to break out of the EHR silo. We need better data, more continuous streams of data. But I would argue that the accuracy that gives me the next best step for the patient for a better clinical outcome is the one that clinicians are going to embrace.
No, that's great. I like that.
I think we're going to end it here. So thank you, everyone, for wonderful questions and attendance. I think next up is lunch. So outside, lunch is outside. So grab food, come back, chat, and I think we're going to go to our next item on the agenda at 12:10. So we'll see you soon.